Welcome, everyone. My name is Samir Kakodkar. I'm a gastroenterologist and specialist in ulcerative colitis and Crohn's disease. Welcome to Against the Grain. If you enjoy this interview, please do check out the rest of my podcasts, which can be found at the website samir3.podomatic.com, or you can search my first and last name either in YouTube or Twitter, and you can find more information there. On Facebook, you can search Against the Grain to join the private group where there are ongoing discussions about these podcasts. Today, we are going to tackle coronavirus, specifically SARS-2, which causes the disease known as COVID-19, in relation to gastrointestinal symptoms and disease. I will be interviewing Dr. Kaushal Majmudar, who is one of our great GI fellows at Advocate Lutheran General Hospital. He recently did a grand rounds for our GI department on this very topic and went over all the recent data regarding pathogenesis, treatment, and also recommendations from various GI societies for specific clinical scenarios regarding liver disease, endoscopy, and inflammatory bowel disease. This will be valuable information for clinicians in all specialties and definitely for those working in GI. Though at times this may become technical, it will be valuable for patients too. At the end, I will give my own thoughts about COVID-19 and inflammatory bowel disease. As a disclaimer, we are not the CDC or members of the committees creating the guidelines that will be discussed. Our opinions are our own. This is an open discussion and should not be interpreted as medical advice. Please, thank you so much for coming on and sharing what you learned.
Thanks for having me.
So give us some information, some general information about what the coronavirus is.
Sure. So the coronavirus, it's called a coronavirus because it falls in this family of viruses. So it's the scientific name for it is SARS-CoV-2. And it's called that because it's very closely related to the original SARS virus, which is known as SARS-CoV-1. And the reason this group of viruses are called coronaviruses actually has to do with the specific conformation of the virus. So the structure of this virus is it's a single-stranded piece of RNA genetic material. It's enclosed in an envelope, and off that envelope are these spike glycoproteins. And these spike glycoproteins are arranged in a crown-like conformation, and so that's why this is called a coronavirus.
So can you tell us a little bit about, we hear in the news all this stuff about these ACE receptors, these ACE2 receptors, which are supposedly kind of how the virus accesses cells. So can you tell us more about that?
Sure. So the ACE2 receptors those are things that human cells express. So human cells have these transmembrane ACE2 receptors. And what happens is there's some interaction between the spike glycoproteins on the SARS-CoV-2 virus and the transmembrane ACE2 receptors. And once there's that binding, the virus undergoes endocytosis and is introduced into the cell. Once it's inside the cell, then it hijacks the machinery and starts undergoing viral replication and the cell lysis cycles that we know how viruses spread. So the ACE2 receptors are critical in the SARS-CoV-2 virus being able to enter human cells.
Yeah, there's been some questions about the use of ACE inhibitors, or these medications that help to control blood pressure, and also angiotensin receptor blockers that have a similar effect but work differently. My understanding is that that's still like a controversial thing if it potentially could make things better or worse. I guess theoretically they would lead to increased expression of these ACE2 receptors. That's what some people are saying. But I don't know if you got any sense if patients are on those types of medications, are hospitals telling people to stop those, or is it kind of like institution dependent?
Yeah, it's a really interesting topic because it's kind of one that we worked through physiologically. We've kind of a few different people have looked at this. The European Society of Cardiology has looked at this and said we should keep patients on ACE inhibitors and ARBs at this time. One of the concerns that's been raised is if you stop these medications in patients that are already on it, they could become hypertensive. And there seems to be this hypertensive surge as these patients crash, and that may be related to some relation with the ACE2 receptor. And, between the ACE inhibitors and the ARBs, if you look at it, there's a whole pathway of this, but theoretically, of the two, ARBs would be more likely to lead to increased ACE2 expression. But ultimately, there was a paper in New England Journal of Medicine earlier this week that pretty much they looked at this in depth, and they said, in patients that are already on these medications, do not stop them when they're hospitalized, do not stop them when they get sick.
And what about the ACE2 expression in the GI tract? And what tissues do, in general, express this ACE2?
Yeah, so predominantly ACE2 receptors are expressed by alveolar type 2 epithelial cells, so cells in the lung, different types of epithelium along the GI tract, kidney cells, and then endothelial cells of the blood vessels. And, the discovery that ACE2 is present in the GI tract is kind of a recent discovery. So there was a study out of China that's going to be published in Gastroenterology. And what they did was they collected serum, nasopharyngeal swabs, stool, and tissue samples in 73 hospitalized patients. And they found that, first of all, the viral RNA is found in about 4% of the stool samples. And that, they went in and did endoscopies on these patients, and they found a high expression of ACE2 on some of these tissue biopsies that they did in the stomach, in the duodenum, and in the rectum, so in the glandular epithelium of the GI tract. There was low expression in the esophagus. And similarly, they also stained for the actual viral nucleocapsid protein and found similar distribution. So not much in the esophagus, but high expression in the stomach, duodenum, and rectum. So there's evidence that this virus directly invades the stomach, duodenum, and rectum in the GI tract, and that's probably why we're shedding the viral RNA in the stool.
So I am aware of a case report that was published recently. I'm not sure if you took a look at that as well, but a case of colitis, which they are supposedly attributing to coronavirus. And the way it presented on colonoscopy was there was scattered areas of erythema. And I looked at the pictures, and it looked pretty mild. It was definitely not severe inflammation, but just kind of scattered erythema. So that is something to keep in mind. And also the consequences of a potential fecal-oral spread of this virus. Some people have made recommendations. I know everyone's wearing masks and worried about touching their face and breathing it in. But what about public bathrooms? There, some, I don't know, Katie, if you have any comments on that.
Yeah, so as part of that same study that I cited, they actually found that even patients that had cleared their nasopharyngeal swabs, their stool studies remained positive for up to 12 days. So about a quarter of patients had persistently positive stool viral RNA, which has raised a couple questions. Number one, is there fecal oral spread? And that question that you raised has also been raised by our GI societies, that we should probably be advising our patients to avoid public restrooms. And then the second question that it raises is, is checking a nasopharyngeal swab really the best way to see if someone is still capable of spreading the infection? Perhaps stool samples might be more appropriate if we shed it longer in the stool. I think we don't know. The jury's still out on that because we don't have enough data to know what the real ramifications of having this stool viral RNA is. Is it truly infectious, or is it just, going into the GI tract when people cough and aspirate? So we don't really know at this time.
And there's no stool test available at this point, right?
From a widely public health standpoint, no. It's mostly academic.
Okay. I wonder if they could just use the nasal swab and put it in the rectum. I don't know if that would work. Maybe not. But
yeah, I don't know. That's a good question. I don't know.
When do patients become infectious in relation to symptoms?
So this is a pretty important topic, and there was a really nice paper on this that came out I want to say the end of February, early March. What they did was they took patients that were high exposure risk but had not developed the virus, and they just started checking their viral loads on a daily basis. So these were asymptomatic people that were high risk of getting the virus. And what they found was that 44% of patients were infectious before ever becoming symptomatic. So about 2.5 days before you develop your first symptom, you are infectious. And actually, peak peak infectivity, so the point where you are most infectious, that occurs half a day before you develop your first symptom. And, this study, I think, really highlights what has made this virus so challenging from a public health standpoint. It's highly infectious. It's got a relatively longer incubation period compared to other diseases like Ebola. And so we can spread it to a large population before anyone's even aware that they even have anything wrong with them.
So you're actually more infectious before you develop symptoms. Is that right? Compared to when you're like in the throes of the disease, if you eventually develop the COVID-19?
Yeah, according to this study, that seems to be the case.
Okay. So can you talk about the virus's ability to survive on different surfaces? People who are kind of holed up in their homes and apartments and are ordering stuff from Amazon or with Instacart, getting everything delivered. What does the actual data say regarding the survivability of the virus on different surfaces?
Yeah, that's a really important question, I think. So this was published in New England Journal just this week. They wanted to look exactly at that because we're all quarantining at home to try and prevent spread and having all this social distancing. But if you're getting packages shipped to you, then you have to make sure that's still protecting you from the virus. So they looked at this, and they actually compared the SARS-CoV-2, so this ongoing pandemic, and they compared it to the previous SARS-CoV-1 virus. And they looked at how the virus lives in different settings. So first they looked at it in aerosolizing, so how long does it live in the air? And that's really important because that would require airborne precautions. So it seems to live at least about 3 hours or so in the air, and it decays over that period of time, but at least 3 hours in the air. It doesn't live very long on copper, about a day on copper. But if you look at cardboard, it lives about 2 days on cardboard. Stainless steel, it can live for 3 days, maybe even longer. And plastic is 3+ days, 3 or 4 days. So that point you raise is if you're getting material shipped to your house, you should be sanitizing them probably before you start using it, especially food products.
Okay, and the specific way to do that, I guess nobody knows the optimal way. What I've been doing, and this is just anecdotal, is if I'm getting a package that doesn't contain something perishable like food, I'll just leave it on outside my door for like 2 or 3 days. And then even after that, I'll go out with gloves and kind of wipe it down with a Lysol thing. I'm not saying that works or that's the best way to do it, but that's what I've been doing. But it also depends like where you live. Sometimes you can't really leave packages out for that long. And, there's a risk of somebody taking it or something like that. So I guess it's on an individual basis what you actually do. I guess if you live in like an apartment building and you have like a mail room, you could probably leave it there for a few days. But I guess from what you're saying, cardboard is like around 3 days, right?
Yeah, cardboard's about 2 days, 2 or so days. Stainless steel and plastic are about 3 to 4 days. Looks like.
Okay, but the problem is food deliveries because you can't really leave that out for too long, depending on what kind of food you're ordering. So I've heard some people get really strict with this. I've heard of some people, if they like order food from a restaurant, they'll actually tell the delivery person just to leave it at the front door. Then they'll go out and actually empty the food into different containers and then bring it inside like in Tupperware and then like throw the containers provided by the restaurant away and then just like cook the hell out of it. That's what people are doing. Not everyone's doing it. And there is this kind of this scale of how seriously people are taking this. Even there are people who are afraid to even go to the grocery store now, and are just getting things on delivery. And a lot of people are avoiding going to the grocery store and just kind of eating what they have until they have nothing, until like the last second. So I don't know what the right approach is, but it's good to know that this data exists for specifically how long this virus lasts on surfaces. So next, can you discuss and you did this really nicely yesterday, the pathogenesis, or like how COVID-19 comes about, and specifically looking at the You mentioned this direct cytopathic effect of the virus, a direct injury to the cells, and then the cytokine storm, which is what ultimately can lead to patients getting very sick.
Right. So there's at least two distinct stages of damage that we know this virus causes. So the first one that you talked about, the direct cytopathic effect, what does that mean? That refers to the virus itself invading a host cell directly and causing damage by causing cell lysis. And that's an early finding in this disease. It seems we have evidence that occurs by 96 hours. So comparing to other types of coronavirus, even the types of coronavirus that are the common cold, that usually takes around 6 days. So it happens rather quickly with this specific virus, which could be representative of how infectious it is and how likely it is to invade once it's reached your body. And so it's this direct cytopathic effect that is the target for some of the antiviral therapies that we're hearing about. Now, contrast that to the cytokine storm. So this is the hyperinflammatory state that your body triggers in response to a progressively increasing viral load. And your body triggers the cytokine storm, and you have release of all these pro-inflammatory cytokines, IL-1 beta, IL-6, IL-8, CCL2, CCL3. And I mean, there's just a lot of players here. But this cytokine storm is a later finding, so it happens usually a few days into their onset of disease, and it's probably why patients seem to crash. And it's most likely responsible for some of the COVID-related morbidity and mortality that we see, like ARDS, cardiomyopathy, and so on and so forth. And, the question has kind of been raised, is this cytokine storm really just a form of secondary hemophagocytic lymphohistiocytosis, or HLH? And HLH, just to remind everyone, HLH it's a hyperinflammatory syndrome. It's characterized by overproduction of these cytokines, and it causes multiple organ failure. And this disease is usually associated with viruses, and people usually present with fever, cytopenia, so low blood count lines, and then markedly elevated ferritin levels, which are all findings we see with SARS-CoV-2. And so that's kind of why some of the immunomodulators are being pursued as targets for therapy. It's based on this physiology.
Because we're going to talk about inflammatory bowel disease towards the end of the talk, and IBD, the therapies that are used, a lot of them target cytokines. So just within that context, so we can think about it later, what are the major cytokines involved in this cytokine storm? I know you mentioned a few of them just recently, but if you can kind of go over some of the major players.
Sure. So the ones that we know are contributing are IL-1 beta, IL-6, IL-8, CCL2, CCL3, CCL5, CXCL10. So those are the ones that we have, I think, the most data about. And IL-6 is kind of an interesting cytokine because it's kind of a complex molecule. It's both pro and anti-inflammatory depending on where it acts. And it's this molecule that's been the target of a lot of therapies and interest because this seems to be one of the primary drivers of this whole cytokine storm.
Yeah, IL-6, just as an aside regarding inflammatory bowel disease, I did look this up prior to this podcast, and there are case reports of people with IBD getting better with therapies targeting IL-6 and people getting worse. So, as you said, the immunology of it is relatively complex, and it's unclear because they are studying some treatments that target that, right? And we'll talk about that later. But I'm just wondering if somebody has IBD and they end up having to take that, is their IBD going to necessarily get better or worse? But we can get into that later. I guess it's unclear. And then what about this encephalopathy? You mentioned some of these patients with COVID-19. Encephalopathy, for the patients listening, is pretty much an altered level of consciousness, right? Like an altered mental status, like people get confused. So, and they're observing apparently this in some patients with COVID-19. Can you talk a little bit about that?
Yeah. So one of the big questions one of the important questions that's being raised is this encephalopathy that they're seeing in patients with really severe SARS-CoV-2, is this representative of direct viral invasion into the cerebrospinal fluid, so the fluid that coats our brain and spinal cord, or is this something else? And I looked at some case reports, and they did lumbar punctures, and they did not find any viral PCR or viral RNA on PCR of the CSF. And but IL-6 can cross the blood-brain barrier. So whereas the virus may not be crossing the blood-brain barrier, if these inflammatory cytokines like IL-6 and some of these other ones are able to cross and cause inflammation, it could be the cause of encephalopathy in these patients.
So one way I can think this would be relevant to the clinician, to the gastroenterologist on the front lines, seeing patients in the hospital, if potentially somebody may have cirrhosis and they get this COVID-19 and their encephalopathy gets worse. So differentiating, is this related to worsening hepatic encephalopathy? So patients with cirrhosis can develop confusion, and it's a very well-known symptom of decompensation of cirrhosis or cirrhosis getting worse. So differentiating the two, I can see would be a challenge. I mean, maybe you get pneumonia level, but we know, maybe an initial level can give you a clue, but it's not necessarily the most accurate thing. So it's just helpful to know that encephalopathy can be associated with this, and if someone has underlying liver disease, there could be an alternative explanation. Mm-hmm. So what about this thrombotic cascade, the importance of this potential if you have COVID-19 having this prothrombotic state, and how that can lead to a poor prognosis? Can you talk about that?
Yeah, so this is something that's really hypothetical at this point, and I guess the question that's being raised is, as a result of the virus, as a result of the cytokine storm, are patients developing kind of like a massive, widespread microvascular thrombosis similar to dengue or DIC, something like that? And the question where that's coming from is there are multiple reports at this point of patients who seem to develop this really severe ARDS, the severe hypoxemia, and even as they recover and you may be able to extubate them, all of their labs improve except for their D-dimer, and their D-dimer is a product of clotting, and so they'll see uptrending D-dimers, and then suddenly these patients will crash. And so the question of, is this something related to a dysregulation in the thrombosis cascade? And I think that it raises a lot of interesting questions. And for instance, heparin is being investigated as a potential therapy in patients with severe COVID that have uptrending D-dimers. So that's something that we don't know at this time. They are studying it in vivo and in vitro to try to figure this out.
Have you spent some time in the ICU yet at our hospital?
I have not, no.
Okay, so I'm just wondering, is this something that's on people's radar as far as the D-dimer? Are they checking that? Are they giving heparin? I guess we don't know. And, one thing I've noticed is it's really institution dependent based on what their protocols are. Even a few weeks ago, I was looking at different protocols from different hospitals, and everyone's kind of doing their own thing at this point and just going off data that's not the best, small numbers of patients, low quality data, and coming up with hopefully things that help, but we don't know.
Yeah, it's quite interesting because I think we're all very used to being very kind of critical of literature and studies, and usually you have time to put 6 months, 8 months in doing a trial and just the planning stages, and then executing the trial over a year, and then studying your data, and so you have this time to be really scientific with how you design your study, how you interpret it. But in a setting like this, where time is of the essence, and it's really just physicians are just trying to share their observations globally with their peers as quickly as possible to try to find something to help patients. And so, yes, I think one of my overall impressions just going through reading 40 or so studies was that the quality of these studies is really not great, but I can sense the urgency to share findings. That's the sense I get in reading a lot of this literature.
Yeah, I mean, obviously it's a dire situation. Whatever has a signal that could be helpful. Sometimes you just feel like rushing out and giving it to everybody. But it's tough. Like every treatment has risks, has been potential risks associated with it, and in medicine, the way medicine has evolved, it's become more and more evidence based, and it's not sufficient to have a case series or even a randomized controlled trial that's like underpowered or doesn't have enough people in the study or isn't designed properly. Under normal circumstances, people would disregard it. It wouldn't even be published in a high-impact journal. But now that we have limited time, these kind of preliminary findings are being published in higher-impact journals just so we have a clue. But there is this danger of going down a road that is actually not effective or trying a treatment and giving it to a lot of people, and it's actually not effective. There's been countless examples of treatments that looked promising with the initial studies, with initial like phase 1 studies, and then once they actually did the large phase 3 trial, it ended up not working at all, not being better than placebo. So, but yeah, it's unprecedented times for like how to figure out what's working in this particular disease.
Yeah, absolutely. Mm-hmm.
So what are the common symptoms, like the GI symptoms associated with this virus? This is a problem. Even I'm experiencing it where I'm getting phone calls from patients who have various things like irritable bowel syndrome, or they may have, functional dyspepsia, or even inflammatory bowel disease, and they have a little bit more diarrhea or something. And then there's this worry, do I have this virus? Do I need to go to the emergency room and get tested? So what are the facts regarding the GI symptoms and COVID-19?
So overall, by and far, the most common symptoms still remain non-GI symptoms. So fever, cough, fatigue, those are still by and far the most common symptoms. Now, initially, the data out of China, initially reported kind of a low incidence of GI symptoms. But as time has gone on and they've done more and more, they've included more and more patients in more cases, and as the disease has spreaded westward across the world, we're seeing that's kind of changed. So, in a recent cross-sectional study of about 204 COVID-positive patients in China, they reported about 50% of patients with GI symptoms. 47% of those 50%. So most of those had both respiratory and GI symptoms, and then just a very small number had just GI symptoms alone. So just 3% out of the 100% only had GI symptoms. And the symptoms that are most common are 79% of patients have loss of appetite. So anorexia is by and far the most common GI symptom. 34% have diarrhea, 4% have emesis, and 2% have abdominal pain. And that diarrhea may be related to direct viral invasion of enterocytes, altering the gut wall permeability and leading to diarrhea. That's kind of the theorized physiology behind that. And it's these GI symptoms are important because diarrhea and loss of appetite are likely the reasons that COVID positive patients become dehydrated and require rehydration. But as we know, a lot of these patients do have significant predisposition to develop ARDS. And so when you're rehydrating these patients, it is kind of a balance.
So the key message there, I think, is that the vast majority of people who have digestive symptoms also have respiratory symptoms. So, although there's this very small percentage that just have these isolated GI symptoms. But for the purposes of triage and taking phone calls from patients, and also for the patients who are listening, if you have GI symptoms and no particular shortness of breath, fever, like the usual things we associate with this condition, I think it's less likely but not impossible that you have the COVID-19. Would you agree with that statement? Or?
Yeah, I agree. Okay. I agree completely.
Okay. Yeah, I mean, I just got a call a few days ago from somebody who has irritable bowel, and her usual bowel frequency was, I believe, like 1 to 2 bowel movements, and then just one day it became 4, and there was also some associated mucus in the stool. So, ultimately I said, no other symptoms really. So we're just kind of monitor and wait it out. I didn't tell her to go rush to get a test. And I know testing, depending on where people are listening from, it seems like it's a mixed bag. In some places, it's easy to get testing. In others, like they only test people who are actually getting admitted to the hospital at this point. So it's really dependent on your location as far as what the protocols are.
Yeah, and with regard to those symptoms, I think that you've highlighted a challenge that I think a lot of physicians and patients are just facing across the world, is that this virus causes a lot of symptoms that are seen with a lot of other problems. My wife's an ER physician, and she always calls this virus the great mimicker, because everyone that comes into the ER, she's like, well, could this be COVID? It could be, I don't know. Could isolated fatigue? And so the question is always being raised is, could this be COVID? And in the absence of widespread available testing, I think that's one of the challenges that's being experienced just across this nation, but across the globe.
Sure, that's a great point. And it also makes me wonder, are we missing a lot of other stuff because we're so focused on COVID-19 and looking for this and maybe attributing a lot of symptoms to it? Maybe we're missing something else, like something like a new diagnosis of celiac or even inflammatory bowel disease, or like a new diagnosis of that. Do you have any sense of if there's actually blood in the diarrhea? Did they mention that actual bloody diarrhea?
I didn't see anywhere mention GI bleeding. I didn't see that.
Okay, probably not. Yeah. So, what is the usual clinical course as far as prognosis? What percent of patients, hospitalized will have ARDS, and like the mortality? Can you give us some sense of that at this point?
Sure. So I'm kind of getting this from our Italian colleagues. Kind of published a very nice overview of how this disease seems to have a usual clinical course. So on day one, which is day one of symptoms, not day one of the virus itself has about a 2 to 12 incubation period before from the time you contract the virus to the time you may have your first symptom. And the symptoms on day one are usually fever that's not responsive to antipyretics like Tylenol, and then a dry cough and malaise. And about day 5 to day 7 of their after that, they'll develop shortness of breath, increased work of breathing, and their oxygen saturation will drop below 93%. And following that, it seems like patients just crash within a matter of hours. They can develop ARDS requiring mechanical ventilation, requiring proning. They can develop severe sepsis and septic shock, and then go on to develop at some point in this clinical course cardiomyopathy, and that's where some of this sudden death is coming from. In terms of data about these outcomes, so we probably heard that overall 80% of patients will have a disease course that will not require hospitalization, whether it's mild, whether it's minimally symptomatic, whether it's like severe flu-like symptoms, but you're okay at home. So 80% seem to do okay at home, somewhere between 10-15% getting hospitalized, and somewhere between 5 and 10% requiring ICU admission. And in those that get hospitalized, it looks like about 40% develop ARDS of the patients that get hospitalized. And if you develop ARDS, you have about a 50% chance of mortality. So that's those are pretty high numbers, and those are kind of scary numbers, but that's what the data looks like right now.
Okay. And for the non-physicians listening, pretty much the terms we're mentioning, ARDS, sepsis, cardiomyopathy, these are just the bad things that happen with severe disease. ARDS is acute respiratory distress syndrome, cardiomyopathy meaning just generally heart issues, heart not functioning properly. And so those are concerning numbers. Another initial thought we had with this was that it was affecting mostly old people. Older people would have bad outcomes, but now we're seeing, it's still mostly in those age groups and older people, but now we're seeing some, deaths in pretty much all age groups now. So it is something to keep in mind, no matter what age you are, to take precautions. So, can you talk about the testing, the diagnostic testing? Like, how accurate is the testing we have, and what's available?
Yeah, so the testing is a really key part of this. So In terms of ways to identify this virus, there's really 4 main ways to identify it. By and far, the most common way is something called PCR. So what I'm referring to with that is they do a nasopharyngeal swab. So they get kind of really to the back of your nasopharynx. They take a swab of the fluid there, and they essentially test it for evidence of viral RNA. And that has about a 63 to 67% sensitivity. So it's pretty low. So if the test is positive, it means you have it. That's that's very high likelihood you have it. But if the test is negative, that does not mean you do not have the virus. So if you have a high pretest probability, you probably have to get a second test, maybe the next day. And they initially, the way we even identified this virus was actually through bronchoscopy. So a BAL or bronchoalveolar lavage, which is where you stick a scope down into the lungs and suck out some of the fluid. That's how we initially identified this virus. Now, we're not really doing that at all nationwide because it's an aerosolizing procedure. You really risk exposing healthcare workers, and it's an invasive procedure. So we're not really doing that as much anymore. Some of the other ways, so serology, this is essentially checking to see if you've got antibodies present against the virus, and you develop different types of antibodies. There's antibodies for the short term, antibodies for the long term. And it's not really useful for the acute infection. It takes somewhere around 7 days from the onset of symptoms before this turns positive. So that's not really helpful in terms of case tracking and quarantining and diagnosing in the ER or at the hospital. But it's probably going to be extremely important from a public health standpoint going forward. At some point in the future, it's going to help us know, number one, who has antibodies that we could potentially collect to administer as plasma to really sick patients, take the antibodies from someone that's already beaten the virus and give it to someone that's fighting it in the ICU. And then serology will also be really important in assessing the true prevalence rate in a population, and that will let us identify a more accurate true case fatality rate. Molecular testing is kind of a new kid on the block. So this is really just announced this week. This is that point of care testing that you might be hearing about. So it's very rapid. It only takes about 5 to 15 minutes. And the way it works is they do a nasopharyngeal swab. So you still got to get the swab, and they amplify the RNA using a reverse transcriptase, which is like a genetic printer. So you amplify the RNA present, and then you use fluorescent labeled probes that have an affinity for the amplified genetic material, and it tells you qualitatively if the RNA is present. So you don't get a titer, you don't get a load, you just tell you if the virus genetic material is there or not. And then the fourth way is the stool testing I talked about earlier. It's not routinely done. The only potential advantage is that we know that there's prolonged viral shedding in the stool. But it's not really widely available, and it's just not being done.
Okay. Yeah, we got an email from there's some variability in the actual tests people are using, right? Because wasn't there a test that was developed by the World Health Organization, which I'm not sure if we use that or we're using our own test or what. I feel like there's some variability in the specific tests people are using, right? And so at least an email that we got from the hospital was saying it was more in like the 90% sensitivity, right? Yeah, that was sent to us. So it's unclear. I don't know what the numbers that you cited, the 60-something percent sensitivity, what specific test that is, and is that the test that other places are using? It's impossible to tell. So, but hopefully it's accurate enough to make some difference. So let's see. And what about the lab findings? What are the? And you briefly alluded to this before. But when we look at the labs, like a CBC, CMP, what are the expectations if you have COVID-19?
Yeah, so, on a CBC, patients seem to have lymphopenia, so low lymphocyte counts, and they can develop thrombocytopenia. So those are the cytopenias that I mentioned before. On a chemistry panel, you might see elevated ferritin, elevated CRP, ESR. Those are just inflammatory markers, elevated LDH. An elevated D-dimer, which is a result of clotting that I mentioned earlier, and then an elevated CPK or creatinine kinase. When you do a liver panel on these patients, you'll see an elevated AST and ALT. And the bilirubin might be a little bit elevated, but it's predominantly the AST and ALT that will be up. And the albumin could be low. And the albumin seems to correlate with more severe disease. And then in immunology studies, you can actually check an IL-6 level. And so that would be elevated in severe cases. And then, you can infectious studies, there's a procalcitonin, which is a way of looking for kind of evidence of an invasive bacterial infection. So as you can imagine, procalcitonin is usually normal in these patients. But if the procalcitonin is elevated, that does portend more serious disease. And that's probably because it points to the presence of a superimposed bacterial infection. So these patients might have neutrophilia in conjunction with a elevated procalcitonin, and that could be the evidence that there's a bacterial infection as well. And so some of those labs I mentioned do correlate with that HLH type disease. So the high ferritin, the high CRP, ESR, the high LDH, and the cytopenias, those are consistent with an HLH type disease.
Yeah, can you imagine if a patient actually had a new diagnosis of HLH and showed up to the hospital today?
Yeah.
Ooh, that would be a tough one to differentiate. But what about, a lot of our colleagues are getting called for liver enzyme elevation consults in the hospital. And, how do we manage that? How do we conceptualize that as far as what are the recommendations?
Yeah, so there's a really great a webinar that was made by AASLD, which is our liver disease society, and that's where some of my data is coming from. So that's a good source. And essentially what we're seeing is about 14 to 53% of patients are presenting with abnormal liver function tests or liver panel. And predominantly, like I said, AST and ALT are elevated more so than the bilirubin and the low serum albumin. And the reason for this hepatic involvement is potentially multiple reasons. So in vitro data, so studies done in a lab, shows that there is increased expression of ACE2 in cholangiocytes. And those are a cell type that live in the liver. And so the question if there's a direct cytopathic effect in the liver that's contributing to these abnormal LFTs is hypothesized. But there are other reasons for these patients to have abnormal LFTs. So some of the drugs we use one is known to be hepatotoxic, one is theorized to be hepatotoxic. So tocilizumab and remdesivir, those are the two drugs I'm talking about. So if your patients are on those could certainly be contributing to abnormal LFTs. And then this could be a result of the hyperinflammatory state. Certainly HLH can cause abnormal LFTs. So the cytokine storm could be contributing to abnormal LFTs, or if your patient is ischemic or anything like that. So there's multiple reasons for these patients to have abnormal LFTs. And there's actually, we have some histologic evidence of what might be going on in the liver. So they did do an autopsy of a patient with abnormal LFTs who died of COVID in China. And on the biopsy, it shows moderate microvesicular steatosis, so fat inside the cells of the liver, and mild lobular and portal activity without any evidence of fibrosis. And looking back at previous coronaviruses, we did see evidence of direct viral invasion in SARS-CoV-1. We did not see any evidence of direct viral invasion in MERS. So perhaps the distribution of the effect on the liver of SARS-CoV-2 is probably more similar to SARS-CoV-1 than MERS. Great.
So we have some guidance here about what to do if we see elevated liver enzymes. What about imaging? Should we get any imaging? So you said the usual so it's more of a hepatocellular pattern. Is that what you said?
Mm-hmm. Okay. Right.
So we're not going to usually shouldn't see an elevated or a significant elevated ALK phos or a T-bili. Is that right?
Correct.
Okay.
Correct.
Okay.
You might see a mildly elevated bilirubin, but it's more so hepatocellular. And the guidelines on what to do here in terms of imaging. So kind of it's really being underscored. Avoid any unnecessary imaging unless you really have a suspicion of biliary obstruction or cholangitis. I think a lot of the times, our gut instinct is to just to get an ultrasound on these patients with abnormal LFTs because it's easy, it's non-invasive. But at a time where we're trying to protect our healthcare workers, protect our ultrasonographers, optimize utilization of PPE, protect our transporters, our nursing staff. If it's not going to be changing your management, if you're not looking for acute hepatobiliary or pancreaticobiliary disease, then we probably don't need to be doing the imaging. If they do have abnormal LFTs, you can check for viral hepatitis, so you could look for Hep B and Hep C, which you should do, but you don't need to do imaging workup routinely.
Okay. What about these chest X-ray and CT chest findings? Are there characteristic findings that are pretty much make the diagnosis very likely?
Yeah. So really at this point in time, the CTs are certainly higher sensitivity and give us more detail. That's always the case. The chest X-rays can show bilateral opacities. It's this viral pneumonia is usually bilateral, but the chest X-ray can actually be initially normal in up to half of patients. And as the inflammation catches up, then you start to see this florid bilateral opacification. On the CT scans, though, you would see bilateral ground glass opacities, which is not, it's not pathognomonic for COVID, but in the right clinical setting, in the right clinical history, especially someone that's got an exposure risk or that just clinically seems like COVID, and they got a CT scan and they have these widespread bilateral ground glass opacities. A lot of these are just being treated as presumed COVID, especially in places that may have test kit shortages.
This hydroxychloroquine is in the news a lot recently. It seems to be what everybody's focusing on. So can you tell us a little bit about how that works and about the study, that initial study that everybody kind of looks to when trying to say that it's an effective medicine?
Yeah. So the way hydroxychloroquine or chloroquine or Plaquenil, I mean, they all refer to essentially the same kind of drug. The way it theoretically works is it interferes with fusion of the virus with the host cell, and also interferes with cell receptor glycosylation. So it seems to primarily affect the direct cytopathic stage of the virus. There is some evidence that there may be immunomodulation with regards to altering TLR or toll-like receptor signaling. So there may perhaps be a benefit in the cytokine storm portion of this. And where the idea to even use this drug came from is when they first picked up on this virus in China, the first thing that researchers did was in vitro say, okay, what drugs were successful in treating SARS or MERS? And so they looked at 5 drugs, and the 2 that showed benefit were chloroquine and remdesivir. So that's where the idea to use these drugs came from. So, initially they looked at this in China. They gave it to patients. They seemed to get better. So that led to this French study that was published in early March. And this study, there was essentially 3 arms to the study. They gave patients either placebo or Plaquenil, or Plaquenil plus azithromycin. And the use of azithromycin was up to the researchers, and it was just to prevent bacterial superinfection. That was the utility of it.
So this was just to interrupt this. So this was not a randomized. Was it randomized?
No, this was a non-randomized trial. It was an open label study. So essentially, these researchers just gave the patients medications and see what happened. And it was a small study. It was about 36 patients, and they looked at the patients over 6 days and checked their viral PCRs every day. And what they noted with this was that patients that received both Plaquenil and azithromycin had 100% viral clearance by day 5, compared to the Plaquenil only group, which was 57% by day 6, compared to the placebo group, which was just 12% by day 6. Now, this is not, like you said, this is not a randomized controlled trial. This is not, there's a lot of issues with the methodology of this study, which is certainly understandable in the setting of what they're dealing with. But the point is that this data is not the highest caliber. I think it's more hypothesis generating and saying this may be an early signal to investigate this. So there are 2 ongoing clinical trials looking at this, one for primary prophylaxis and one for post-exposure prophylaxis, I think, out of University of Minnesota. So that's kind of where this is headed.
So for the non-physicians who are listening, the importance of randomizing, is that, it eliminates the bias because it seems like this study, the physicians decided which patients got placebo, which patients got Plaquenil, and which got combination therapy with azithromycin. So could there be this subtle bias where they're only choosing patients who they think are going to do the best and give them this treatment? I'm not saying that's on a conscious level, but there could be this kind of subconscious bias. And also randomizing helps to kind of like normalize the confounders, all these extraneous or these other factors, these variables that could influence things. When you randomize, it kind of normally, or it distributes them supposedly evenly amongst the groups so that you can really focus on just the intervention and if that's effective. So that's, I guess, would be the problem if you agree with this study. Although I didn't look at it into detail. Would you agree with that?
Yeah, I agree. Okay. It is. That's exactly correct.
Okay, because I don't know if they did give a table regarding like the severity of disease amongst the treatment groups. I don't even know how they would classify that. I don't know. Did you actually see if they actually did a breakdown of like, was there like a table 1 for the patients, like their gender, age, disease, comorbid conditions, all the potential confounding factors?
I don't remember. I think They might have. I can't recall accurately off the top of my head.
Okay. Yeah, I mean, it's impossible. You went through like all the studies that were published in the last few weeks, and there's no way you're going to remember every single detail, and that's fine. But if people are interested, you should go check out this stuff. Don't take our word for it. If you're interested in knowing more, I definitely encourage everybody to actually look into the studies, look at the data yourself, and come to your own conclusion. So, and then there's this, and we won't go into this much detail, but hydroxychloroquine, the risk everyone by now knows, there's arrhythmias or QT prolongation to get monitored with EKGs, right? Like every other day or every few days, get a baseline and make sure that's not getting worse, even though overall it's relatively rare. And then another thing you mentioned was this retinopathy thing, right? Which you're supposed to get eye exams every year, apparently, if you're on hydroxychloroquine. But this is going to be a short course for most people, so right. I don't think that's going to be an issue. But if this eventually gets approved in a prophylaxis, like if healthcare workers suddenly are taking this on a regular basis, who are on the front lines to help prevent them from even developing the infection, then that would be one to keep an eye on, the retinopathy, even though my understanding is that's pretty rare too.
Yeah, it's a pretty rare thing, and it's kind of like patients get yearly ophthalmologic exams just to screen for it, but something to be aware of, yeah.
Okay, and then just briefly, if we could just real quick go over the remaining treatments here. I don't want to get into too many of the details, but remdesivir, what's the word with that?
Yeah, so remdesivir was this is initially a drug that was made in 2015 for Ebola. The idea here is that you interfere with the direct cytopathic stage, so it has no immunomodulation. It just affects viral replication. It was approved for compassionate use on March 20th by the U.S. government, but because there's kind of a shortage, Gilead, the company that makes it, kind of rescinded it, and now it's really just being used in clinical trials unless your hospital has a store of it left. So there's only in vitro data for effect. There is some in vivo data for MERS, but we have no data on it for SARS-CoV-2 as of now.
Okay, and just to be clear for the non-physicians, in vitro meaning it works in a test tube, right? But we don't know if it actually works in actual human subjects. But it seems to have an effect on the virus in a test tube. Okay, so what about tocilizumab?
Yeah, so tocilizumab, this is kind of where a lot of the interest is stemming from, because tocilizumab blocks the IL-6 cascade. So what it does is it binds the IL-6 receptor, and by binding the IL-6 receptor, it prevents IL-6 from binding and leading to downstream JAK-STAT signaling. So you don't get this downstream inflammatory signaling. And it's kind of an easier drug to give. I mean, it's essentially you give one dose. You can give up to 2 doses, up to 12 hours apart. But we have no published data on this. There's trials underway. Now, important for our gastroenterologists is that there are some known GI side effects. So number one, there's a known significant hepatic injury risk of about 20 to 30%. And there have been cases of, acute liver failure resulting from this. So it can be pretty significant. There's also an increased risk of GI perforation, specifically with diverticulitis. So that's something to keep in mind, especially if someone's going to undergo, colonoscopy or something like that, and they have a bunch of diverticuli and they're on this drug. So that's something important for our gastroenterologists to know.
So how is this given? Is this an infusion, injection? What is this?
I don't know if it's a sub-Q injection or infusion. I actually don't know that. I think the dosing it's 4 to 8 mg per kg, but I don't know the route.
Okay. And is it just one? It's probably just one dose, or I'm not sure how it's being given, but
yeah, it's usually one dose. You can give up to 2 doses 12 hours apart, which I don't know what the availability is. So whether we're rationing this or not, I don't know.
Okay. And then convalescent plasma. What do we need to know? What's the take-home point? You mentioned this before already, but
yeah. So plasma that's using antibodies in someone that's already cleared the virus, giving it to someone that's got severe disease. The data we have, it was published in JAMA. They had 5 patients. Again, this is not a randomized trial. They just gave 5 patients convalescent plasma and see how they did. And it reduced viral load. It downtrended the fever curve. Their SOFA scores, which is a measure of symptomatic disease severity, that got better, and then their ARDS seemed to improve. So this is not, really strong evidence, but it's it being investigated more because of this finding.
Lopinavir, ritonavir.
Yeah, so this is an anti-HIV medication, and again, early on when they first discovered this disease, they initially were looking at a lot of in vitro. They looked for in vitro benefit first before seeing what should be used in vivo. So this had in vitro benefit, and they, as a result of that, they did a randomized controlled trial. So this is one of the few drugs we do have good data for. Unfortunately, the data didn't really pan out. So they took 199 patients with severe SARS-CoV-2, and to sum it up, there was no difference in clinical improvement. There was no difference in mortality. There was no difference in viral RNA levels. And 1 in 7 patients had severe adverse events that made them stop the drug. So at this point, there's no role for this medication in severe COVID. The question has been raised, is there a role for this early on? So it's still being used by a lot of centers, and the cocktail of medications are used to treat, to try to see if maybe has early effect in reducing viral replication.
Heparin. What about heparin?
Yeah, so heparin, I kind of brought this up earlier, and again, this is being investigated because of the question of DIC and microthrombosis. So they did a randomized controlled trial in China of 449 patients with severe COVID to see if giving prophylactic dose heparin had any effect on the outcome. And in their primary outcome, there was no difference in patients that got heparin and those that didn't get heparin. But in a sub-analysis of their data, what they found was that patients who had evidence of severe coagulopathy, so in those patients with severe disease who had that uptrending D-dimer, that worsening INR, the thrombocytopenia, when they got heparin compared to their non-heparinized peers, they did have a 28-day mortality benefit. So certainly should be giving at least prophylactic dose heparin or enoxaparin to your critically ill COVID patients. I think that's mostly standard of practice in ICUs in general, across the U.S. at least. But that's something that's being investigated further now.
Another potential mechanism of how heparin could be helpful is being anti-inflammatory. Heparin is known as a blood thinner, but it has been actually studied in inflammatory bowel disease, and there's some preliminary evidence that it can help overall the course of inflammatory bowel disease. How that happens, the theory is that maybe there are certain aspects of heparin that actually bind to cytokines 9 specifically, and may actually decrease inflammation itself. So that's just a thought I had. I don't know if necessarily in this particular condition that's how it may help. But that's just something to keep in mind. So you went over a paper about the U.S. outcomes. You're right. There was a publication was it from Washington?
Yeah, it was Seattle. Mm-hmm.
Okay. Can you talk about that one?
Yeah, I mean, and this is important because this is, I think, some of the first data we have, to my knowledge, that's coming out of U.S. patients and patients treated here. So this was a multi-center study out of Seattle, Washington. They just concluded the trial on March 23rd and published it within a week. So that's very impressive to that team. So they had 24 patients that was included in this study. And, they were primarily, this study was designed to just look at outcomes, just see how many were in the ICU, how many got really sick. So of their 24 patients, 75% ended up on ventilators, 71% required vasopressors. The median length of stay was 17 days, and the median duration of mechanical ventilation was about 10 days. So that, number one, that underscores the impending ventilator shortage that we keep hearing about. It's because, it's not usual to have so many patients require ventilators and to have them be on ventilators for almost 2 weeks. And so that's where this bed shortage and the ventilator shortage, I think, urgency is being raised. The other finding from this study that was really stood out to me was that the overall mortality in these hospitalized patients was 50%. And that number is probably underrepresented. When they cut off the study at March 23rd to publish the data, but when they cut the study off, when they censored the study, 5 patients were still in the hospital. So that 50% mortality is probably underrepresenting the true mortality. And, these were not, very old patients. I think the median age was around 61. So that's kind of our early data. And one of the other data points that I thought was interesting from this study was that 0 patients, had traveled to a country where COVID-19 was endemic within the past 3 months. So this is all community spread. And only 50% of those were known sick contacts. So only 50% of these cases came into contact with someone that they knew was sick. So that probably refers to that earlier discussion we had where peak infectivity seems to be occurring before symptom onset. So there's clearly widespread community spread in Seattle and a lot of asymptomatic carriers of the disease.
Okay. Yeah, this is scary numbers, extremely scary numbers. So but we'll see if that pans out in the rest of the country. Mm-hmm. And in your presentation, you talked about immunosuppression with respect to other kind of common GI clinical scenarios that come up on a daily basis. So what about patients with autoimmune hepatitis? What is the general guidance there?
So this guidance, again, this comes from AASLD. So for autoimmune hepatitis in patients without COVID, you don't need to change anything in their management. For patients that do become COVID positive, number one, you need to consider minimizing the dosage of high-dose prednisone. You may not be able to get them off it completely because if you're on it for a long period of time, you may need a low dose to prevent adrenal insufficiency. But for their calcineurin inhibitors or their mycophenolate, especially if your patients have lymphopenia, fever, or pneumonia, dose reduced by about 50%. So that's something that you should strongly consider doing. And, really use caution in initiating prednisone, where potential benefit might be outweighed by the risks because steroids, as we know, can prolong viral shedding. So there's some data about those outcomes.
How about alcoholic hepatitis?
This is a challenging topic. I mean, it's really going to be on a case-by-case basis. I mean, certainly this new idea to use a day 4 Lilly has been raised, and I think this is a very appropriate time to be using day 4 Lillies to see if steroids could be stopped early. If your patients are already on steroids, if they're COVID negative and they don't have any of the symptoms, it's probably okay to just continue it. If they do become COVID positive, then I think you really have to look at, how bad is the liver disease from the alcoholic hepatitis versus how severe is their COVID, and really weigh on a case-by-case basis whether to pull off the steroids or not.
Viral hepatitis B and C. What are the take-home points on that?
So the take-home points is to really prioritize the COVID management. So if your patient's COVID positive and they've got abnormal LFTs and you check them and they have a positive infection, it's really questionable to be initiating anti-Hep C or anti-Hep B therapy at this time. If they're already on the therapy, if they're already on treatment, they should probably continue because patients on treatment probably experience some hepatoprotective benefit from being on the antiviral agent, and hepatoprotective against some of the toxicities of the drugs being used to treat COVID.
What about these patients who are due for hepatocellular carcinoma screening or cancer in the liver screening? These patients are supposed to get ultrasounds plus or minus AFP every 6 months. What should we do if we have a patient that is due coming up?
Yeah, so if it's for screening purposes, so those with cirrhosis, Hep B, or anything like that, we should continue usual surveillance. An arbitrary delay of 2 months is reasonable and it may be necessary, just from a practical standpoint. But we should, as this is expected to go on for a long period of time, we should continue with usual surveillance. And if your patients are on treatments already for HCC, we should continue those as well.
And then the questions about liver transplant. Now, one of the interesting things you mentioned during your presentation was this whole thing about donors, liver donors. A lot of people end up getting livers from people who have died, either for multiple different causes. And a lot of people are going to die of COVID-19. And are these potential liver transplant organ donors for liver transplant for somebody else?
It's a really important question, and it's a really good one. Unfortunately, at this time, SARS-CoV-2 positive patients are medically ineligible for donation. And I think that raises a lot of questions like you're asking. We don't know how the rationing of transplants is going to go, how the prioritizing of transplants is going to go. The CMS says don't postpone transplant surgery if it's really indicated. May want to hold off on living donor transplant programs unless someone's got acute liver failure or something like that. But for the patients that are SARS-CoV-2 positive, they cannot donate a liver.
Wow. Another thing is a lot of people are not driving as much. And this is somewhat of a morbid thought, but a lot of liver organ donation happens from car accidents, unfortunately. And that the supply of livers, I remember reading some news story years ago about the rise of people with the automated driving, like Teslas can drive themselves, and eventually a lot of the driving will become automated to the point where accidents are going to decrease big time. And then there's the question, if that's the case, there's not going to be as many livers to do liver transplants. It's just kind of a natural consequence of that happening. And even now, people are driving less. Pretty much you can, at least in Illinois, you can only really drive to your house or the pharmacy or the grocery store. So it seems like people are tending to stay local. So the good news is there's less car accidents. But if you're somebody on the organ transplant list, this time may not be the best time for you to get a liver realistically, because people are dying of COVID-19, which makes them ineligible, and then people are driving less. Of course, people die of other causes too, and can become liver organ donors in other contexts. But it's just a thought that I had. So let's go into inflammatory bowel disease. Now, most of the people who listen to this show are interested in the IBD perspective of it. And, sorry if the initial part was a little bit technical for some of the listeners who are not physicians, but I don't like to dumb things down because I think the best way to explain things is actually at the highest level. And I think my audience for this show is pretty sophisticated, and they do get this, even if they're not necessarily in the medical field. So now we'll talk about inflammatory bowel disease. One fascinating thing in your presentation was you said in China that they had actually stopped all the IBD patients, all of their medications.
Yeah, that was, I watched a recent webinar, I think with Dr. Rubin in the IBD world, and I was actually really surprised to hear that as well. They didn't publish any of their outcomes, so we don't know how many patients flared, how many got emergency surgery, what the effect of that was. And, I wonder if we will see some data on that, but I thought that was pretty astounding too.
Yeah, and also I would doubt they'd probably just stop the ones that were immunosuppressive. Like, I don't think they would necessarily stop mesalamine, but I don't know. I don't know the specifics of it, but yeah, I was surprised to hear that, given that, and we'll get into this, what you could think of what happened downstream if you did that across the board, which doesn't seem like the best of ideas to do, because people may end up flaring and end up in the hospital and getting COVID there, or having emergent surgeries and things like that. And so, but that was very, very surprising to me. So
yeah, I think I think they don't use anti-TNF agents or just biologic agents in general in China as widespread as we do here in the U.S. So maybe it was a little bit easier too. It'd be harder to fathom doing that here in the U.S. with so many patients and all these scheduled biologics and all the challenges that go with that. So I don't know if that plays into it, but I agree completely. Yeah.
Okay. So, yeah, before we get really into that, so there was one more thing I wanted to talk about before we get into IBD in more detail, and that was the endoscopy recommendations. So, one of the take-home points I got from your presentation is that N95 masks are now recommended across the board for pretty much all GI procedures. So can you tell us where that recommendation came from and the rationale?
Yeah, so this came out. I think it's going to be published in Gastroenterology, and it just came out yesterday from the AGA. So all endoscopy should use an N95 because both upper endoscopy and lower endoscopy are theoretically aerosolizing procedures. So certainly upper endoscopy, they can cough, and in a colonoscopy, they can pass flatus. And so both of those are theoretically aerosolizing procedures. And then there's also the question of fecal oral transmission with the colonoscopy. So I think previously we were just using an N95 for uppers and risk stratifying lowers, but now it's just across the board, all endoscopy should use an N95, and that they also recommended that all endoscopy should use double gloves regardless of COVID status. And that comes from there was a study where essentially they did single glove and double glove, and they found lower evidence of the evidence of the virus in patient and providers that double gloved. So that's where that recommendation came from as well.
So is that virus actually on the hands? Is that what they were looking at?
It didn't say, I read a summary. I didn't read that study directly. I read a summary of that study, and they didn't say where. I was trying to figure that out too, where exactly it was, but it just came out yesterday. I didn't really have time to kind of go into it in depth.
Okay, and you also said everyone in the room should be wearing an N95, correct?
Yep. So anesthesia, if it's present, the endoscopist and any techs or GI nurses, they should all be wearing an N95.
And obviously, this is a contentious issue with physicians in certain areas of the country saying they don't have enough equipment. So although this is a recommendation from the AGA and kind of the ideal scenario, depends on where you are if that's actually going to happen or not, unfortunately. So, okay. And then, I remember you did a grand rounds, I think it was a few months ago, about actually the protective equipment, even before this happened. And you mentioned that face mask, I think you made this presentation, the face mask with the shield was actually not that sanitary of a thing to use if it's been in the room for a while, right?
Yeah. So that was actually, I think that was Dr. Solomon, but we actually we kind of discovered that article together. Okay. And that face shields that are left in the room also have the similar amount of fecal particulate material on it. So really you should be kind of storing them away, in a cabinet or outside the room and not just leaving them in the room.
Right. Okay. My bad. Brad, I apologize. But it was a good, definitely a great presentation. Okay. So let's go into the IBD. So I've had some time to just think things over for a few weeks now. I've been mostly working from home. And, following the news, following multiple people's Twitter feeds who are, international experts in IBD. And I can tell you that, there's certain thoughts that came to mind. Now, I'm not the CDC, and Kaushal's not the CDC, and we're not giving official recommendations. Pretty much, I'm in agreement with the CDC and the IBD organizations that have come out with recommendations. But I just had some thoughts, just kind of free association type of thoughts that came to mind that I'd like to share with the audience. And you can disagree with me or you can agree with me or whatever. But I just kind of want to get these out there and you can see what you think. And Kaushal, feel free to chime in if you have any opinions, but I kind of prepared a few points here.
Sure.
So, the first thing is, the paradigm for treating Crohn's and colitis for decades has been medical therapy, right? Like immunosuppressive therapies. And luckily, over the years, these have become safer and safer, especially the newer medicines. But, a main side effect for most of the medications has still been infections to various degrees. The infection risk was previously thought to be, quite rare, and that's across the board with all the medications. I mean, although the main risk was infection, it still was thought to be a rare phenomenon. But happened, occasionally, and we have to stop medicine or temporarily interrupt medication if infections came up. But in the setting of COVID-19, and since it's been such a huge thing worldwide, it's really affecting the consciousness of patients of the whole world. It doesn't even matter if you're a patient with IBD. So it remains to be seen at this point if the medications are a significant risk factor for developing, even getting the virus or having a bad outcome from it. I'll talk about my thoughts on the database so far, but overall, it's weak data. I mean, anybody would say that. Like a patient registry is not an accurate assessment of, this medication is safe or this isn't. It's like pretty much unknown at this point. It gives us some clues, but it's not the best information. So it's a good start, though. But I still think the treatments are safe. But will this shift patients' perceptions? I'm talking about down the line once the curve flattens. Hopefully a few months from now, hopefully. But will the perception of patients change regarding the acceptability of this infection risk from medications? Like I can give you, for example, like you'd think after this is all done, if it does get done with, that there's a lot of people who are going to have family members who've died from this, or acquaintances or someone that they know that died of pneumonia, right? So if you're having these discussions about the risks of biologics, like the risks of Remicade or Humira, or which are associated with increased risk of pneumonia, are they going to be less willing to try a medication that's associated with pneumonia, even though the risk is extremely tiny? We're talking about an absolute increased risk of 1%. But in the setting of this COVID-19 situation, and I feel like people are going to remember this for years to come, is it going to affect medication decisions from the patient's perspective? I think physicians are still going to be comfortable using them, especially if we get like a vaccine and get it under control from that perspective. But, the word pneumonia or lung issues, is that just going to terrify people where they're going to be so risk averse to medications that they're not going to do it? So that's just one thought. Or is this just a temporary blip on the radar that ultimately won't affect this paradigm? It's something that's going to come and go, and people are going to be like, there's a vaccine, this is under control. I don't think this is going to be a repeat issue. Even if it is a seasonal thing, it's going to be like the flu. And even though the flu still kills a lot of people, but it remains to be seen how this is going to. I'm curious myself how patients are going to take this and how this is specifically going to affect their risk aversion. I predict dietary therapy. There's going to be an uptick in interest in dietary therapy just overall, because although the data behind dietary therapy is very, very weak, and there were randomized controlled trials going on regarding diet, and I think it's gaining acceptance over time. But I think more and more people probably are going to be interested in it in the setting of this infection that's gone worldwide. So we'll see. My opinion has always been medicine and diet together. I like using both in the vast majority of people, and I still think after this is all done, that's going to be the way to go. But the medication decisions may be a different conversation depending on what the patient is feeling. So that's my first thought. Kaushal, do you have any thoughts about that?
I think that's a really interesting thought. Not really something I had considered, to be honest. And I think that is going to be really important. I mean, shifting the whole paradigm of management of inflammatory bowel disease based on perceptions of the safety of immunosuppression. I mean, I don't think we've really experienced this kind of jolt to public perception of immunosuppression before. So I think that's a really important point you're making. And I mean, I agree with you. I think it's going to be interesting to see how patients perceive it after this.
Right. Again, I don't think it's going to shift the paradigm. I think the paradigm is still probably going to stay the same. And the risks of the medications are pretty much going to be the same once they come out with a vaccine and we have a better handle on things. But it's mainly the patient's perceptions, because sometimes they're not necessarily rational, which is understandable. I mean, if you have a family member or someone you know died of pneumonia, and then somebody says, we're going to put you on a medicine that's associated with pneumonia, even though it should really have no relation, it's in your memory, it's in your consciousness, and will that affect patients' decisions? And luckily, we have newer medicines that are not associated with pneumonia. Vedolizumab or Entyvio now, and Stelara, not associated with serious infections. So maybe this will cause a shift. Now, will the insurance companies necessarily agree with that? Oftentimes, it's very frustrating, dealing with these insurance companies. A lot of my day is spent fighting these companies, giving them documentation. And though you may have the most current evidence and the best rationale for using a particular medication, they'll come back and just say, "Hey, there's nothing we can do." And a lot of times they try to grind physicians into the ground with just messages and saying, "You have to send this. Then you have to do a peer-to-peer call, and then you have to send an appeal." And most of the time, in my experience, they do approve it if you do have the right rationale, but it takes quite a bit of grit to get through to the end of it. A lot of people just give up and say, "All right, I'm just going to give you whatever the insurance company recommends." But I do make that special effort to go the extra mile to get the right medicine, because I think it's important. Especially if it's your first biologic, the first medication you do. I'm a big believer in getting them on the right medicine and something that has a good side effect profile so they can be on it long term, hopefully, and have a good outcome. So that's my first thought. Second thought. So some of the genetics that lead to the predisposition to Crohn's and colitis have allowed our ancient ancestors to fight infections better. Not all of them. There's been over 200 genes that have been associated with IBD, but some of them are associated with a more robust immune response, and maybe that allowed our ancient ancestors to fight infections better. One example is the CARD15 gene in Crohn's disease. You may have heard the NOD2 CARD15. And there's a theory out there that's actually been published, and I've seen it published by different authors. But in the Middle Ages, in the 14th century, it's possible that particular mutation may have allowed people to better fight the plague, Yersinia pestis. And so it may have killed off a lot of people who didn't have that mutation, but those that did survive. But now that we live in such a hygienic environment, it may be that it's leading to just too robust of an immune response. And there are some theories that Crohn's in a certain subset of patients may be triggered or potentially caused by a bacteria called Yersinia enterocolitica, which is related to Yersinia pestis. So are we seeing this robust immune response to a similar bacteria? Again, this is theory. There's controversy. A lot of people think this is complete nonsense. But it's just another thought I had that, could IBD patients potentially fare better in this COVID-19 situation, independent of medications, because they have these genes that may have allowed their ancestors to fight infections better in the past? So that remains to be seen. And then this theory regarding, I talked about this hygiene hypothesis, right? And Kaushal, have you heard of that? With allergies and allergic conditions, inflammatory bowel disease, there's this theory that one of the contributing factors is that we're too clean. We live in Western societies, there's indoor plumbing, everybody stays indoors all day, nobody goes outside, and everything's hyper-sanitized. So the immune system almost kind of gets bored and rebels eventually, right. and that may contribute to this. So would you say that after this is all said and done and under control, let's say a few years from now, and I feel like it's still going to be in the consciousness of the world, are we just going to get even more hyper-sanitized?
I actually made that exact comment to my wife 3 days ago, that I wonder if we're going to see more, autoimmune disease in the future as we're becoming an increasingly hygienic world.
Exactly.
That's a great question. Yeah.
Yeah, it's a balance, right? I mean, obviously, we got to be hygienic, extremely hygienic right now in this critical area time. But I worry about the future where, especially with children, with child rearing, as far as being too hygienic with them, and then we're going to get this explosion of autoimmune disease, of food allergies, potentially IBD, asthma, because, if the pacifier falls on the ground, we're going to dip it in alcohol before putting it, or not alcohol, but I don't know, Lysol or something, before washing it very carefully before giving it to the baby, or potentially, completely avoiding. I think the handshake is done. I'm not sure anyone's going to shake hands anymore. I actually think from my perspective as a physician, I think that's a good idea. But it's a balance, right? It's a balance. If you get too hygienic, then you risk, just autoimmune disease going out of control. And I unfortunately think that may down the line lead to more IBD. I have no proof for this. This is just a theory. It doesn't mean anything, but it's just a thought I had. Okay. And what about the vaccines? This vaccine that they're supposedly developing. One thing I was trying to look up and I couldn't find the answer. Is this a live vaccine or a dead vaccine? Hopefully it's a dead vaccine so we can give it to our patients who have inflammatory bowel disease, who are on immunosuppressive therapy. In the past, there have been some live vaccines that we can give in the setting of immunosuppression, depending on if it's low level. For example, the old zoster vaccine, we could give that, and it was a live vaccine. We could give that to patients with just, expected regular doses of azathioprine or 6-MP. Now the zoster vaccine is dead, the Shingrix vaccine, so it doesn't matter. But I hope that the vaccine, at least they come out with a dead vaccine. But I think this whole thing that's going on is going to put a serious dent into the anti-vaccine campaign for the time being. We'll see how that evolves over time. But now people are seeing the real consequences of an infection that, although the mortality rate is relatively low, it's still, when it affects a lot of people die. And I think people are realizing that now. So we'll see. We'll see how that goes.
Yeah, it's almost like, the grandparents who all lived through polio and things like that were the strongest advocates for vaccines because they saw how incredibly important they were. And in our lifetimes, I think, or at least in my lifetime, we have the influenza vaccine, but it doesn't have that stark effect like the polio vaccine had, where suddenly all these people were not getting polio anymore. And so I wonder if this is that equivalent for our lifetime. I wonder that too.
Yeah, it's I predict people are going to be pro-vaccine, at least across the board for some time now. But we'll see. I could be wrong about that. Now some more specific things about guidelines, right? About guidelines for IBD, and I know, Kaushal, you looked through some of these as well, but regarding the research, I'll put the links to places where physicians and patients who are listening to this, you can actually look through this stuff yourself. But I just thought I would pick out certain things from this, and with the fellows at our program, we actually have an IBD day. After our grand rounds, I sit with the IBD fellows. The GI fellows, which they may be IBD fellows too, and we talk about different cases. So I think maybe, Kaushal, for this week, maybe we just have the rest of the fellows listen to this podcast. I think that may be sufficient. But anyway, so let's go through some of these guidelines, and you let me know if you have any thoughts about this stuff. But infusion centers, right? So I get a lot of patients sending me messages, should I go get my infusion? They're worried about going to their infusion center because they may get sick there. They're also worried about the medication they're getting. So I did see one kind of guideline that was published in Nature by some of the physicians in Italy, the gastroenterologists there, And some of the things that they suggested were checkpoints at the entrance to screen for cough and fever in the last 2 weeks. I think that's really being done across the board in all hospital settings. Even in our hospital, they're like checking the temperature of everybody that goes through the door, I believe. So, but also some of these infusion centers can be really packed. You know, like you can have 30, 40 people all sitting in this room getting infusions, and these are potentially higher risk people. So that's not good. So one thing that I think would be ideal is if you can get at least 6 feet from somebody else. And these chairs, I don't know, Koshal, if you've actually been to an infusion center, but these chairs are lined up right next to each other, you know?
Yeah. Mm-hmm.
So and I don't know if they're doing that. I was meaning to call one of these infusion centers before this podcast and actually ask what they're doing. But they really should be spacing these chairs out. At the very least, I'm telling patients, if you have a mask, wear it during the infusion, and pretty much, you know, wash your hands after you get out of there very carefully. So that's my thoughts on infusion centers. As far as now we'll talk about medications. Okay, so a lot of the risks ultimately it's unknown. Like nobody really knows. We don't have robust data. It's a brand new virus. Are these medications a risk? But I think I'm glad these GI societies actually sat down with like international experts and scientists and came up with some guidance. I'm very glad about that. And I pretty much agree with everything they're saying. But I wanted to go over specific elements of it. So I do think it makes sense to risk stratify patients, not based on medication class, although that's going to give you a lot of your information. Obviously, you're going to start there, but you also have to take it patient by patient basis, right? I do have a firm belief that just like certain medications work in some patients and don't work in others, also the side effect profiles can be varying depending on, you know, the patient. So I have patients on, for example, vedolizumab, right, and Entyvio, that have been on it and have no side effects at all, have not. And so like there's this theoretical concern about vedolizumab. It's supposed to be very gut specific, right? But there is MADCAM, which is what, you know, one of the elements, how this medication works. MADCAM is what alpha-4 beta-7 binds to in order for these immune cells to get into the tissues from the blood vessels. So there is MADCAM in tonsils, in the oropharynx. So the question is, do people potentially have an increased risk of getting upper respiratory infections or nasopharyngitis with vedolizumab? So I went back into the data again, and apparently the Gemini 2 trial, which was the major trial looking at this for Crohn's disease, looking at vedolizumab, there was a statistically significant increased risk of nasopharyngitis in the Crohn's disease population. But they did not see that in the ulcerative colitis population, the Gemini 1 trial. But then they subsequently did another study in 2018, and it was more of a long-term safety study. And they said there was no increased evidence of upper respiratory infections, though numerically there was a trend towards it. It was not statistically significant. So I think that may be why they are saying that being on vedolizumab is not necessarily an increased risk for getting the infection or getting COVID-19. But, you know, I wonder about that because there are some patients who I've definitely put on vedolizumab and they get more colds. They get more I've had some that get them like every month initially, and usually they tend to get less frequent over time. And I have some patients who don't have any issues at all. No increased risk of upper respiratory infections. And there's some debate, are these really upper respiratory infections, or is it just postnasal drip or something else? But maybe if you do have a patient who has a lot of upper respiratory infections on Entyvio, maybe you have to risk stratify them by that patient and not necessarily the medication, the effect of the medication on a large population of people, but this particular patient in front of you. And I have had some patients who develop pneumonia on vedolizumab too. At least two or three come to mind. And though it's not associated with pneumonia, these patients develop pneumonia. And I wonder if maybe they had an upper respiratory infection, a viral one that ended up becoming super infected and a bacterial pneumonia later on. So for that patient, sure, I mean, in my opinion, I would say you have to be extra careful, take precautions. I wouldn't take them off the medicine, but that's just a thought I had. So one of the questions that comes up is inflammatory bowel disease considered a risk for COVID-19? And Kaushal, I just wanted to see, did you have any thoughts about that? Just having inflammatory bowel disease itself, then I'll give you kind of my thoughts on that.
Yeah, I don't know. It's kind of the question. I mean, it's an underarching question, because if some of our therapies are targeted at suppressing the immune system, are patients who have a suppressed immune system, more likely to do better, or patients that are on immunosuppression? I don't have a clear answer. I don't think there is one in consensus expert opinion at this point in time. I think there's risks and there's risk factors and protective factors, and there's a balance. And I think the one thing we do know is that trying to minimize steroids, but I think beyond that, I don't have a good sense of are they at a higher risk at this time.
Yeah, it's unknown, and according to the the IOIBD guidelines that were updated as of March 26th of 2020, and I'll go into those a little bit more later, but pretty much those are saying that having IBD by itself is not a risk factor for getting the virus or getting COVID-19. But there are some elements about IBD that may not necessarily be consistent with that. Patients who have IBD there's a known increased risk of getting the flu and also getting hospitalized, as well as getting pneumonia. There is a higher risk. Now, is that related to the medications? Probably. But in the setting of pneumonia, they've actually studied looking at invasive pneumococcal pneumonia in IBD patients, and they saw the risk was increased both before and after diagnosis of IBD, and was not influenced necessarily by medications, although they contributed. But they did see a signal that even independent of medications, they may be at higher risk of pneumonia. Why that may be? Because maybe they have a dysregulated immune system at baseline, and they may just be more predisposed to it. So those are some elements that may not go along with the statement that potentially IBD by itself is not a risk factor for developing COVID-19. It remains to be seen, but those are just some elements that may not be necessarily consistent with that. So let's go over some of these statements. And you went over these too, right? The IOIBD. This is the International Organization for the Study of Inflammatory Bowel Disease. They publish these statements, which I do encourage everybody, go to ioibd.org and click they have a button, I think, that's like the current data, and you can actually see I'm talking about the IOIBD is the website that just has the statements, the consensus statements. So these were statements that were voted on by international experts, really people at the top of their field, the basic science, the scientists, the really top clinicians and physician scientists. And so I'm just going to give you the take-home points about these, but you should read through all of these. So the take-home points is that prednisone, 20 milligrams or more, is a problem. Because it is associated with, they're worried about that potentially as predisposing you to the infection and the infection getting worse. And Kaushal, can you share with us why that would be the case? Why are steroids, why are they worried about that?
Yeah, so it seems to prolong viral shedding, right? So if your body's trying to clear the infection you can't reduce that viral load, you're not going to be able to break that cytokine storm. That's the data shows that it prolongs viral shedding, and that's how I interpret that.
Right. But, their recommendation is to try to get people off steroids if possible. But I don't think that's really changing management in the majority of patients, even with COVID-19 going on, because we try to taper people off steroids anyway. We know that this has a terrible side effect profile, and our goal oftentimes is to get people off steroids. It works in the short term.
Right.
So I don't think it's really going to change. People are not on steroids for no reason. They're on it because that's the only thing that's sustaining them. So I think there's very few cases of somebody on prednisone 40 when there's probably been attempts at getting that person off prednisone. If not, that's a mistake. Even before this COVID-19 thing happened, we try to get people off steroids anyway. And they actually have specific statements on what to do. So if somebody is SARS-2 positive, they have a positive test, but they don't actually have COVID-19, which is the disease where you have the severe respiratory complaints and end up in the hospital. So which meds do you stop if you actually test positive but are not sick enough to get in the hospital or don't have the actual COVID-19? And they said prednisone above 20 milligrams, so you probably get below that, preferably off. Azathioprine 6 mp. And that's known, those medicines are known to predispose people to viral infections and potentially severe viral infections. And also this tofacitinib, which is Xeljanz, which is this new medicine we're using for ulcerative colitis. And then they said it's uncertain if someone's on anti-TNF or vedolizumab, which is Entyvio, or ustekinumab, which is Stelara. So that was interesting. It was interesting to me that, like, for example, if Kaushal, if you saw a patient in clinic that had IBD and had some cough and fever, and they go in the ER and they get tested, and maybe they get sent home and it's positive, would your first thought be to, and I think I said on Remicade, right? Let's say they're on Remicade. What would be your first thought? Like, before I read this statement, would you stop Remicade or would you continue it?
Yeah, I mean, I guess it depends on when their next infusion was, what's their history of the disease, of their IBD. Is it really severe? Was getting them in remission with Remicade kind of like a finally situation, or was it just the first thing we did? I guess, I mean, I would be inclined at this time to continue it unless, their COVID becomes really severe and they're intubated in their ICU and they're due for the next dose. And of course, you're going to hold that next dose, I think. Sure. But I don't think I would hold off on it for now because I'd be worried about developing antibodies and losing this whole line of therapy.
Mm-hmm. Yeah, that is a good point. Like, where are they in the timing of the infusion? Because also COVID, SARS-2 and COVID-19, they evolve over time too, right? So what if this person's due for an infusion in 2 days? Are you going to have them get it? Or are you going to delay it a little bit? So these are important questions, maybe delaying it a little bit. It's dependent patient to patient, like if it's somebody who does pretty poorly, if you delay it even a few days, it may be a complex decision. But usually delaying the infusion, for up to a week in somebody who's on like every 8 weeks usually doesn't cause major issues. But yeah, again, overall, I'm in agreement with this guideline. So what if you're positive COVID-19, like you're a sick patient in the hospital with this disease from this virus? So which medicines? So they say if you're on mesalamine, you continue that, right? We don't think, and that was actually a question I got off Twitter because somebody was saying that on the database it looked like more patients that were on mesalamine may have worse outcomes. It's based on pretty weak data there, but they saw the percentage of mortality was a little bit higher in people on mesalamine. And I don't think we can really draw any conclusions from that. Because overall, we don't think these mesalamine medicines suppress the immune system at all. We really haven't seen any signals that there are infections associated with them. So we would say don't stop those. But you should try to get people off of prednisone, at least below 20 milligrams. Also, they're saying you should stop 6-MP, stop azathioprine, stop anti-TNF medicines like Remicade and Humira, and also Stelara, ustekinumab. And they said it was unclear for vedolizumab. So potentially if someone's, it seems like you could go either way. Either you can start it or stop, or continue it or stop Entyvio if someone actually has COVID-19. My opinion is I would probably err on the side. And again, like you said, it depends on where they are in their cycle. Like sometimes you just don't have a choice. If they just had an infusion and they have 8 weeks until their next infusion, there's really no decision to be made. It's more if they're coming up on one. So yeah, it's unclear, and that's based on a patient-to-patient basis. So what about combination therapy? We use immunomodulators and biologics together sometimes, often in the setting of Humira and Remicade and Cimzia and the anti-TNF medicines along with azathioprine. So it's interesting that guideline just said stop the immunomodulator if you have COVID-19. But I think maybe they just forgot to address the anti-TNF too, because they did say in a prior statement that you stop anti-TNF if they have COVID-19. So you probably are going to have to end up stopping both, but they didn't clearly mention that. It's also important to note that patients who have SARS-2 but don't develop the COVID-19 disease can restart their IBD meds after 2 weeks, provided that they don't develop COVID-19. And patients who have COVID-19, once their symptoms resolve and they've had 2 negative PCR tests, they usually can restart their medications as well. So, yeah, so those were my thoughts briefly on the statements. And that's kind of a summary of what they were saying. Overall, and people should not be stopping their medications. Like if you don't have this, if you don't have like a positive test or symptoms suggestive of this, yeah, it's a bad idea to stop your medications because you're scared of coronavirus. Because I'd rather you take precautions. You should just take precautions. But if you stop your medicine, you risk the problem of flaring, ending up in the hospital, requiring steroids, which are going to put you in a much bigger problem. So I think the safe approach is just to continue your medicines if you're not sick, if you don't have this, and just ride it out. And you should check in with your GI physician. Don't wait for them to contact you. Contact them for more information on what you should do if you're on immunosuppressive therapy. So, and then the final thing that I wanted to talk about was this COVID IBD database, which is what I was referencing before. And this is a database where people all over the world are inputting data for IBD patients that they've seen who have COVID-19. And what are the outcomes? And again, I would consider this to be low quality data. It's very difficult to draw conclusions, but there are some signals that may or may not be accurate. From my review of the data, this is what I say. So so far, they have 239 cases. And you can go to covidibd.org and actually look at the database yourself. So at the time I looked at it, and what's the date today? Today is
the 2nd, April 2nd.
Today's the 2nd. So whatever we're saying today may like in a few days may be inaccurate. So that's just a disclaimer out there. This stuff is changing constantly. So don't hold us to this information. But as of today, 239 cases of patients with IBD diagnosed with COVID-19. 4% of Crohn's disease and 11% of the UC patients ended up on a ventilator and died. So as far as the particular medications, it seems like there's a signal that steroids are associated with the highest mortality. And then there was this question about mesalamine, right, that there was a little bit of a higher percentage with that too. But I wonder if that may be potentially some of these patients may, especially if they have Crohn's, maybe they were just not adequately treated, because mesalamine's not a good treatment for Crohn's necessarily for most cases. So maybe they had more, maybe the mesalamine is an indicator of not good disease control. And, we know severe disease activity may be associated with more mortality. So I wonder if that may be an explanation. I'm not sure. But but we did see that. More severe disease is associated with more mortality. Maybe that has to do with the disease, maybe the medications. And also smokers had worse outcomes, and older age had worse outcomes. So those were my take-home points from the actual database. I don't know if Kaushal, you had any other thoughts about it.
Yeah, I think so. Certainly, like you can see that the cases are much more distributed in the western part of the world, and so I think the hope is that you start to see, kind of like you said, some sort of early signal effect. But I agree with you. I think that of course you can't really control for anything here. You can't really get more details on it. It's just kind of a database that's de-identified. So the data is going to be low quality.
Right, and we'll see how it evolves over time. So we covered a lot of ground, and I think this is going to be really helpful, especially for clinicians, for GI doctors, because you really went over the newest data as of today. I'm going to do my best to get this out there as soon as possible, because if I wait too long, this is going to be already outdated. So I'll get it out either today or tomorrow. And Kaushal, can you share with us? How can people find you? Do you have like a website, or do you want people to find you? That's the question. Maybe you don't.
Yeah, I don't mind questions. That's a good point, though. I don't know what the easiest way to reach me would be. I don't have a website.
Okay, well that's okay. I always ask anybody on, is there anything you want to plug? Any book you've written recently, or any? I know you play guitar, right?
Yeah, I play guitar, and my wife and I we do music together. And actually, my wife and I have spearheaded a project related to this, and we're doing like a prospective interventional trial for coronavirus, not really for GI related, actually more for the ER setting. But me and her are working on a project and already enrolling patients. So hopefully a lot of this was done to just understand the disease better before designing the project. And so, hopefully you'll see some prospective data coming from us sometime in the future.
Nice. Okay. And send this to all the GI fellows that you know, and also in our program. And hopefully we can all get back to work in a normal fashion soon, and I'll be able to see you face to face instead.
Yeah, that'd be great.
Yeah. Okay.
Yeah, that'd be great.
All right. Anything else to add? Otherwise, I think we're going to shut this thing down.
Nope, that's it.
All right. Thanks for your time.
Thanks, Dr. K. Sure. Thank you.
No problem.